Good afternoon, everybody. Thank you so much for having me. I want to start off with a little bit of audience participation, a couple of quick questions. How many people out here have ever heard the following when trying to get permission to do something in their organization, government or not, and been told no? First one. That's the way we've always done it. Some of you, hands, it's hard to see. Okay. How about this one? We tried that once and it didn't work. I hear that one a lot. Or my personal favorite, the lawyers will never go for that. Right, I can tell that some of you. Now, I know some of you are not from government. Those of us in government also hear some other things, like, did this get run by the White House? Our appropriation will get cut. If we say yes to this, how do we say no to everything else? Or those people in Congress will never get it together to make that happen. If there's anybody here from Congress, I'm just kidding. We never, ever, ever say that, I promise. Now, I want to give you a sense for what we're dealing with at HHS. A lot of people don't really know the scope of this organization. It's a big organization. We've got 90,000 people that work at HHS, probably 3 times that when you count the contractors. And HHS is made up of 11 of what we call operating divisions. A lot of these you've heard of: Food and Drug Administration, Center for Disease Control and Prevention, National Institutes of Health, Center for Medicare and Medicaid Services, and a bunch more that you might not have heard of unless you're a health policy wonk or deep in the field. But I want to, and what's interesting to me is that each one of these 11 operating divisions operates very much as their own separate entity. They're very siloed. They get their appropriations from Congress in a lot of cases independently of the department. And it's a challenge sometimes to work collaboratively across the department. Now, just to give you a real sense of what this is like, let's go a level deeper and take a look at NIH. NIH itself is made up of 27 institutes. Again, each one of these institutes is a relatively separate organization. It's a lot of them, again, get their appropriations from Congress. The Office of the Director doesn't necessarily have very detailed control over them. And there's a lot of overlap of missions, and a lot of times it's difficult to encourage collaboration. Now, just for fun, let's go one level deeper and look at the National Cancer Institute. NCI has got 28 bureaus or offices or divisions, and again, we see the same problems in terms of silos and the ability to collaborate. Now, I actually could have gone a few levels deeper here. The guy who was making these slides for me started to get carpal tunnel and revolted, so I told him to stop. But this, I think, is a great illustration of the challenge that we're facing, which is that in today's world, we need to be able to, as a government, react to change in a much quicker way. We need to be proactive. We need to be rapidly responsive to things when they come up. We need to move from this universe of a bureaucratic, command and control-oriented, risk-averse, red tape-filled organization and move to a world that's much more risk-aware, much more able to be agile, much more interested in sort of challenging the way things have always worked and doing things that are potentially experimental to move forward in the right way. And that's where this organization called the HHS Idea Lab, that's the idea that it was born from. Our mission is very simple. We want to create essentially a more modern and effective government through this thing we call innovation, which has a lot of different definitions. Now, how do we do that? Really, we focused on 3 very straightforward things. Number 1, we want to invest in our internal workforce. We've got 90,000 employees at HHS. Many of them are incredibly intelligent, incredibly dedicated to the mission, and are all there for the right reasons, but their hands are tied by bureaucracy, by red tape, by fear, by culture, you name it. And so we're trying to figure out how we can change that. Secondly, we want to bring people in from the outside world, from unusual sources. We want to go to places that we don't typically recruit federal employees from and recruit them. And then third, we want to build cross-department communities that have where we can break down the silos and bring people together to do interesting things. So I'm going to talk about each one of these in a little bit of detail. The first one, focusing on the internal employees. So we call this our investment pipeline. The first program, HHS Ignite, is an internal accelerator. I'll talk about that in a second. Second one is a ventures fund. You can think of this as traditional risk capital. We want to be able to take money and invest it in things that have shown some promise and some potential, but are still a little bit too risky for the standard lines of funding in operating divisions. And then finally, an employee recognition program that really tries to call out people who have challenged the status quo in some way and help show that we really care about this kind of stuff by inviting them to a ceremony with the secretary, giving them a small check, showing them that we really believe in this type of activity and that we want to see it continue. So to talk a little bit about Ignite, this is one of our newer programs. Basically, it's a 3-month program. Teams apply. The ones that are selected are given 3 months worth of time, $5,000 to play with. And what's interesting about the money is that it's literally the least important part. Many of the teams never actually use a single cent. And most importantly is methodological training, which we partnered with the University of Maryland School of Entrepreneurship. We put them through a 3-day boot camp where we teach them things that are never taught in government: human-centered design, design thinking, lean startup, business model canvas, stuff like that. And then over the course of those 3 months, we regularly check in with them to try to make sure that they're moving along, that they're iterating rapidly, they're collecting data, and they're doing all kinds of interesting things. So I'll tell you one quick story from this most recent round of HHS Ignite. There were these 2 women who worked in the White River Service Unit in Arizona. One of the operating divisions of HHS is the Indian Health Service. Many people don't know, but we actually operate a health system. We have 120 hospitals scattered across the country in reservations and tribal areas. And these 2 women worked in the White River Service Unit that actually grew up there. And they realized that there was a problem. And the problem specifically was that the emergency room visits in the White River Service Unit were about 3 times the national average. Now, this is actually systemic across the IHS. And the reason for it is relatively straightforward. It's a cultural issue. Folks in the Indian reservations and tribal areas tend to go to the emergency room for pretty much everything: prescription refills, physicals, true emergent situations, you name it. Now that leads to a problem, which is that the wait times, obviously, get much longer. Wait times on average in IHS facilities are 2 times the national average, which leads directly to a big problem, which is that people leave without being seen. Now, obviously, if it's an emergent situation, you don't want to leave without being seen. That has some pretty serious consequences. But even in the case where you're there for a preventive visit or a prescription refill, these are important activities to actually take advantage of, and it's really much better if you can actually do the thing that you're there to do. So these 2 women were accepted into the Ignite program, into the last cohort. And after the boot camp, they sat down and they had created their business model canvas. And their idea was pretty simple. It was to basically put an electronic kiosk in the ER waiting area and have people self-triage. So when they got in, they could push a button that said, "I'm here for a prescription refill," and they could then go and get that done. Now, one of the things we teach is talking to your customers, talking to your users. So they talked to their users and they found out that that actually wouldn't work. It turns out that again, culturally, there wasn't enough of a familiarity with this kinds of technology. People weren't comfortable putting their issues into the machine. And so it never would have been accepted as a mechanism to get this to work. So they said, all right, let's go old school, and let's create a paper form. And let's give this paper form with some simple checkboxes to the receptionist at the emergency room and have that person triage so that they could send them on the right way. Turned out that didn't work either because these are small communities and people are very reluctant to give a non-medical professional information about a medical condition. So, all right, let's give the form to an EMT or a trained professional, put them in the ER. Well, that didn't work either. There's a law called EMTALA, which basically says if you walk through the door of the emergency room, you have to officially be triaged before you can actually be seen. So they thought, and they were kind of nearing the end of the 3 months here, and they had to do something. And then they came across this idea that actually has taken hold in the private sector called the fast track ER. So they looked at their process and they said, okay, what's the current design look like? Well, people come in, they get into the ER, they get registered, they go into a full triage facility, and then they wait. And they wait for a long time in IHS hospitals. So they said, why don't we try something different? Let's greet a patient with a health technician. If it's an emergent situation, we'll direct them to the right place. If not, we direct them to one of these triage rooms. They do a quick triage, and if it's something straightforward, like a prescription refill or a well visit or what have you, they go into one of the fast track rooms, they get dealt with, and they get to go home. Now, what's interesting is that they tested this. And they tested, because we're big fans of metrics and figuring out if things actually work by experience, and so they tested this over a 4-day period in the White River Service Unit ER, and the results were remarkable. They went from nearly 18% of the people in the period immediately preceding that leaving without being seen to just over 1%, okay? Now, what's even more interesting is that they did a calculation of the ROI, and they realized that with an $80,000 investment, they can actually capture $6 million of lost and uncaptured revenue into this system. And by the way, this is all of our money, right? This is taxpayer dollars. That's one hospital in the IHS system. Imagine if they did this across all 120, okay? These are 2 people, 3 months, pivoting on ideas. And that's what I love about HHS Ignite. We teach people new ways of doing things, we give them the space to do it, and they blow your mind with what they can come up with. Second thing that we focus on is bringing external folks in to solve problems inside the department. We have 2 in-residence programs. One of them is called the Innovator in Residence program. It's where we partner with a nonprofit that has a similar topical interest to HHS. That nonprofit funds a 2-year position in the department to work on that topic, not a specific problem, just a general topic. But the one I want to talk a little bit about today is the Entrepreneurs in Residence program. This is one where we basically solicit complex problems from across the department where the operating divisions or the lower level divisions don't have the skills or resources they need to actually solve that problem, and then we recruit from the outside world somebody to come in for a period of no more than 12 months to work on that program. The 12-month thing is really important because with 12 months, you, by definition, if you only have 12 months to solve the problem, you almost by definition have to do things differently. You cannot follow standard bureaucratic procedure. And so one of the folks that came in the first round was a guy named David Cartier. He was a 25-year veteran of UPS. He had worked on all kinds of innovation units there. And he came in to solve a problem with organ donation. One of the HHS divisions, HRSA, has part of it, one part of it actually is responsible for the nation's organ donation and transplant system. And they realized that they had some kind of a problem in terms of not being able to essentially track, electronically track organs from when they were procured from people into the recipients. And so they brought David in because David is from UPS. He has all this experience with RFID tagging and tracking and could help them do this. David, however, had experience with innovation practices and design thinking and human-centered design and realized that he needed to actually understand the problem a little better. So he spent some time in operating rooms, a whole bunch of time actually, and realized that the problem was much farther upstream. Specifically, the problem was that the operating room surgeons and the technicians and the nurses literally had to spend a whole bunch of time, often late at night, writing between 30 and 70 handwritten labels. Ones that look like this, ones that are maybe a little more or less complicated that look like that. But they had to do this over and over and over again. There's a great challenge with transcription errors, with all kinds of other things. Plus, it takes time. And when you're dealing with organs, every minute counts, right? You want to do things as quickly as possible. So David went back to HRSA and said, listen, the problem that you want me to solve is not the right problem to solve. The right problem to solve is to figure out how to do this. So he developed a mobile printing and barcode sort of labeling system that can be used in the operating rooms, and then proceeded to test those with several of the 58 organ procurement operations that exist in the United States. And the results of this, again, were pretty amazing. He's actually still collating the final results, but the anecdotes that we've heard, he took the system away after the pilot because the idea was we're going to give you the system, we'll test it out, we'll get some data back. Every single OPO that had used the system were like, wait, no, don't take that away. We need that back. And to me, that's like as good as you can get, right? The users of the system want to continue to use it. So that's the HHS Entrepreneurs Program. The final piece that I want to talk a little bit about is this idea of essentially creating or catalyzing these cross-departmental communities that are designed to solve complex issues across the department. The idea here is that anybody can create a community under the Idea Lab and therefore under the Secretary's banner as long as it meets 3 major criteria. Number 1, that there's a defined and accountable leader. Number 2, that there's a well-articulated mission statement that everybody in that community can sort of recite and understand. And number 3, that there is a set of defined, time-bound, milestone-based metrics that we can actually track to make sure that things are progressing along as they should be. To date, most of these communities, and I should say these communities exist of people across the department at all levels. That's an important piece, right? In order to break down the walls and to break down some of the hierarchical barriers, you need to get people involved in these things from across the board. To date, we have spooled up most of these. There are a couple that are being spooled up now that are outside of of my staff's actual purview. But one of our newest ones that I want to talk a little bit today is procurement. Procurement is a problem. And I think everybody in this room has experienced in some point in time the challenges with government procurement. As a result, we have created this thing called the HHS Buyers Club. It might be my favorite name for anything we've done. But the goal is to fix procurement in the federal government. This all started actually in the wake of healthcare.gov last year. One of the reports that I read was from a group called the Stanish Group, which basically said that essentially almost all projects over $10 million are challenged or fail, right? 42% of the time, IT projects over $10 million fail by just not launching. 52% of the time, they're challenged by either being over time, over budget, or they don't end up doing what they're supposed to do when they do launch. Now, even if you take these numbers with a grain of salt, and even if they're not quite accurate, I would argue that it's still a problem. This number should be very, very, very small, right, as opposed to very, very, very big. And so we created this thing called the Buyers Club. Now, the Buyers Club has a few main purposes. One of the things that we want to do is essentially teach people that the Federal Acquisition Regulation is not a sort of a chiseled in stone document, right? What's interesting to me about many of the laws that we have in this country, including the FAR, is that there's a lot of room for experimentation. There's a lot of room for interpretation. We have chosen to interpret it in a specific way, given the interests of time and getting things done in a rapid fashion, but it doesn't lead us to the best outcomes. And so one of the things that we've done is looked at a lot of different innovative contracting mechanisms and tried to break them down into almost like a flowchart-based system that a contracting officer or program manager can use to make some very rapid decisions based on the characteristics of their project and try some new ideas, try out some new mechanisms. The other thing that we want to try with this is getting the procurement team together from day one. So I'm a big fan of agile development. One of the hallmarks of agile development is that you've got everybody who's necessary, QA people, developers, product managers, et cetera, on little teams together all the time working on delivering small pieces of code. I see no reason why we shouldn't do the same thing in procurement. Let's get a program manager, a contracting official, the lawyers, whoever else is necessary together from day one and incentivize them not on their little piece of the pie, but on the overall outcome. If a contracting official is incentivized to deliver a piece of technology or an implementation correctly at the end of the process, as opposed to just delivering on the procurement, we're going to get a lot better outcomes from this. And we're going to get better solutions. Now, part of this is that we actually want to put our money where our mouth is and try some of these things to create case studies so that people can follow along relatively easily. So one of the first ones that we did was with the Assistant Secretary for Planning and Evaluation. They wanted to do a relatively straightforward project, new web presence, internet and intranet, and rebuild a couple of applications that they had currently built on their existing website. And so when we got involved, it was sort of the standard procurement, right? 40, 50 pages long, every requirement you could possibly think of, your traditional RFP. And we sat down with them and managed to basically take that set of requirements and condense it, remove basically everything. We got it down to about 6 requirements out of the hundreds that they had. And I actually thought we could have gone to 0, but you know, that's for next time. But we released this document, and instead of requesting vendors to give us back the standard litany of responses about checking the boxes of yes, we can do all these things, we said give us an 8-page concept paper. A concept paper that describes how you would help us achieve the business goals that we're trying to achieve here. And give us a bid at the same time. We got 24 bids, 24 concept papers. From there, we down-selected to 5. And then we paid each one of those 5 people $10,000. And we said, take that $10,000, go away for 3 weeks, or work with us for 3 weeks, I should say, and come back with a prototype, something that we can actually look at, play with, and evaluate for how it actually works and how you actually built it. And they did. And out of those, we got a few. These are just some examples of the prototypes we got back. The winner was this one right here that we selected, and we selected the winner based not only on the technical proficiency of that prototype itself, but also on the way that their team worked together and worked with us. So what's great about this is at the end of the process, right, we have already got working technology, so we're out of the gate with something that we can build on, but we also know the team. And we know the people, and they know us, and the business objectives are fairly clear, and we're doing this in an agile way so we can actually develop something quicker for less money that's going to have much, much better, a much higher quality of deliverable. Now, Just to wrap up, look, this is a nascent thing, this Idea Lab, right? We have had just over 1,000 people kind of come through Idea Lab programs in some way, shape, or form, which is a little over 1% of HHS. I mean, it's a big place. But I know we're having an impact, and I know we're having an impact because instead of hearing things like, that's the way we've always done it, now we're hearing, let's test and experiment. Instead of hearing, we tried that once and it didn't work, now we're hearing things like, it's okay to fail as long as we learn from it. And instead of hearing things like, the lawyers will never go for that, well, we're still hearing that one. I don't know, I actually don't know how to fix that problem. But just to leave you guys with one last thought, Charles Kettering, the inventor, said, if you've always done it that way, it's probably wrong, and I completely agree with that. So on that note, thank you guys very much. Really appreciate the time.